Hello everyone, I'm Shamali Vakhtare, the clinical head from third year, part MBBS part 1. Let's start with the topic anatomy snippets. This is the snippet number 5, and the topic is applied anatomy of pleura. So first we will understand what is pleural cavity. As you can see in the diagram, there is mediastinum in green color. So there are two pleural cavities on either side of the mediastinum, surrounded by lungs. Superiorly, the extent is above the rib 1 into the root of neck, and inferiorly extend to a level above costal margin. A medial wall of each cavity is the mediastinum. So with this knowledge, we will try to understand what is pleura. So each pleural cavity is lined by a single layer of flat cells, that is mesothelium, and an associated layer of supporting connective tissue. Together they form the pleura. The pleural cavity is divided into two major types based on the location, that is parietal and visceral pleura. So now we will see the differences between parietal and visceral pleura. It will help us understand the concept of referred plane when we start the applied anatomy. So the difference between parietal and visceral pleura. Visceral pleura is originated from splanchno-pleuric mesoderm and parietal from somatopleuric mesoderm. Visceral pleura is supplied by sympathetic nerves of T2, T5 ganglia and parasympathetic from vagus. Parietal is supplied by thoracic and phrenic nerves. The visceral pleura is insensitive to pain and parietal is sensitive to the pain. So the referred pain is seen in parietal pleura. Vessels are bronchial vessels in visceral pleura, like they supply the visceral pleura, and intercostal and pericardiophrenix vessels supply the parietal pleura. The tracheobronchial lymph nodes are present in visceral and intercostal lymph nodes in parietal. Now we will try to understand the surface markings of the pleura. As you can see in the diagram, you can see different markings, and we will see the even ribs first, that is the 2, 4, 6, 8, 10 and 12. It follows a particular route, like both the sides parietal pleura comes close near the second rib, as you can see. At 4, you can see the cardiac notch, that is the left pleura does a lateral shift to accommodate heart. At rib number 6, you can see the lateral diversion. And rib 8, there is mid-clavicular line. And rib 10, it follows the route till the mid-axillary line. And it goes back at the 12th rib. So the parietal pleura is thicker than the visceral pleura, or we also call it pulmonary pleura. It is divided into costal, diaphragmatic, mediastinal, and cervical. So the costal lines the thoracic cavity. Diaphragm and the costal is also attached to the layer of areolar tissue called endothoracic fascia. Diaphragmatic lines the superior aspect of diaphragm, covers the base of lung and continues with the mediastinal and costal pleura. Mediastinal lines the surface of mediastinum, reflected over to the root of the lung and becomes continuous with the pulmonary pleura around the hilum. The cervical pleura extends up to neck and above the medial 1/3 of the clavicle. So we will see the recesses of pleura. There are two recesses of pleura which act as reserve space for the lung to expand during deep inspiration. That is costomediastinal recess and costovertebral recess. Costomediastinal is in relation to the cardiac notch, and costovertebral lies inferiorly below the costal, between the costal and diaphragmatic pleura. The costomedial recess lies anteriorly behind the sternum and costal cartilage. See the applied anatomy now. Yeah. Starting with paracentesis thoracis. So it is basically the aspiration of fluid or removal of blood or pus from the pleural cavity. It is called paracentesis thoracis. The patient is supposed to sit in upright position so that the fluid is collected in recess below. So the indications for this is pleural effusion, pneumothorax, and emphysema, or not emphysema. Emphysema is a contraindication, so keep it in mind. Another contraindication is coagulation, like coagulation disorders. So we will, in short, try to understand how it is done. To avoid any damage to the intercostal nerve and the vessels, the needle is inserted superior to the rib. As if you can see in the diagram, below the upper rib, there are vessels. So we have to make sure that it doesn't insert there. So it penetrates skin, fat, and muscle. Inserting the needle into ninth intercostal space in the mid-axillary line during expiration will avoid inferior border of the lung, and the injury will be, like, we can try to avoid the injury. The needle should be angled upward to avoid the penetrating deep sides of recess. Yeah. The next thing is pleurisy or pleuritis. Pleuritis is basically inflammation of pleura. It may be dry, but it often is accompanied by the collection of fluid in the pleural cavity. The condition is known as pleural effusion, like the collection of pleural cavity. Dry pleurisy is more painful as during inspiration both the layers come in contact and there is friction. The resulting friction is detectable on auscultation. Yeah, these are some causes, symptoms, and treatment of pleuritis. It is associated with stabbing, pleuritic chest pain, high-pitched breath sounds, and dry cough and shortness of breath. The treatment includes NSAIDs to relieve the pain, antibiotics if it is associated with pneumonia, meds to prevent the blood clots. So we will try to understand pleural pain with the help of a case. A 10-year-old male had been having sore throat, cough, and fever. On the third day, he developed severe cough, dyspnea, and pain in the right side of the chest, right shoulder, and around the umbilicus. So they are asking us the probable diagnosis and the reason why it radiates to the right shoulder. So pneumonia is the probable diagnosis. As we have seen in the theory part that parietal pleura is sensitive to the pain, and the costal part is supplied by the intercostal nerves. Also, the mediastinal and central parts of diaphragmatic pleura are supplied by phrenic nerve, that is C4. The pain is referred to the tip of shoulder, as this area is also supplied by supraclavicular nerves with the same root value as phrenic nerve. So as they have the same dermatome, it is like the referred pain is to the shoulder. Also, in case of umbilicus, the costal part supplies the anterior abdominal wall, like the skin of anterior abdominal wall. So it might radiate to umbilicus as well. Yeah. So these are some conditions on which the questions are asked most of the times. Pneumothorax, the entry of air into the pleural cavity, as in case of bronchopulmonary fistula resulting in collapse of lung. There can be many other etiologies. Basically, pneumothorax means entry of air into the pleural cavity. Hydrothorax is accumulation of significant amount of fluid in pleural cavity a result from the pleural effusion. Hemothorax, presence of blood in the pleural cavity as seen in case of injury to major intercostal or interthoracic vessel than from a laceration of lung. So hemothorax is basically presence of blood in the pleural cavity. Hemopneumothorax, if both air and fluid both accumulate in the pleural cavity along with blood, there is air fluid level or the air fluid interface will be seen on radiograph. So it is a like diagnostic sign of hemopneumothorax. Emphysema is presence of pus in the pleura. It is commonest cause of like pneumonia is the commonest cause of emphysema. So yeah, we can see like the how the injuries can be avoided, where the injuries have to be avoided during the surgical procedures, as the pleura extends beyond the thoracic cage at right xephocostal angle, right and left costovertebral angles, right and left sides of root of lung, as cervical dome of pleura. The pleura may be injured at sites during surgical procedures, like in case of dissecting around esophageal hiatus and from an incision in posterior abdominal wall when procedures expose the kidney. Yeah, thank you.